And before we get started where we left off with arteries and veins, I just want to see if there are questions you would like to have answered, things that you would like to talk about before we add new material. Yeah?
So what does high friction circulation mean in the systemic circuit?
So you said high friction and then systemic. Those terms? Yeah. So those are some of the things that we'll definitely get into today. But as we are looking at our circulation patterns, there's three main kind of loops or circuits of the body, right? So there's the one that's to and from the lungs, starts with a P. What's that one? Pulmonary. So there's a pulmonary circuit. That's the kind of odd one where our arteries are blue and our veins are red because we're headed to those organs. We're sending deoxygenated blood to those organs in order to pick up oxygen. So the blood coming back to the heart from those organs are very brightly red colored instead. And we'll see that today. Some of us have seen that already in the fetal circulation as well. When we have these specialized blood vessels going out and from the placenta, those also have that opposite coloration to them. Okay? So we have pulmonary circuit. We have the coronary circuit. Where's that going to and from? The heart itself, right? So the coronary or cardiac circuit are those blood vessels we've been learning in lab, like the right and left coronary artery and the great cardiac vein and stuff like that, that serve the heart itself. And then we have the systemic circuit. So the systemic circuit are those blood vessels that are going to and from the body. So that is where our red arteries are going to be and our blue veins are going to be, right? So going arteries away that are going to be red, veins that are in blue that are going to be coming back. So to and from the body is our systemic circuit. Okay, so we'll take a little bit of that today, but then we're also going to be looking at, like I said, hemodynamics. So things that affect blood flow and blood pressure around the body. So we already got a little bit of a peek in that when we were talking about the heart, because we quantified something that's called cardiac output, right? So cardiac output was equal in this very simplified equation. Cardiac output was equal to what two things? Heart rate, right, times stroke volume. So that's how much you get in an individual squeeze or individual contraction of our ventricles, right? Systolic contraction of our ventricles. And then heart rate, how many squeezes you get per unit time. That gives us cardiac output. So certainly cardiac output, and we said that there are various things that can affect cardiac output, right? So sympathetic and parasympathetic stimulation, different types of hormones, like if you're having an adrenaline rush or something like that, and there's epinephrine going around, that can affect either one of these, and that affects cardiac output, which affects blood flow, which affects blood pressure, right? Because that's the pump doing all the work. Now, as we're broadening our horizons, we're getting to all of these circuits, these blood vessels. And what we're going to be talking about is that because it's all connected in a big loop, certainly what happens to the heart is going to affect blood pressure and blood flow. But what happens anywhere along these circuits, along these loops, will also affect blood pressure and blood flow, right? So we'll talk about, one of the big ones is diameter of the blood vessel. So we already got an introspective in that when we were comparing our arteries and veins, which is what we see up there, right? So oftentimes veins have a bigger lumen, a bigger opening, and arteries have a smaller one. Arteries are really kind of directing the blood flow and making sure they don't blow out with their thicker wall and things like that. But veins, on the other hand, on the other side of this loop, have very low blood pressure on a relative scale compared to arteries because they're really far away from the heart. And as they've gotten further away from the heart, they're further away from that pushing force, and the blood that's going down these blood vessels is slowing down. It's losing pressure because it's dragging along the walls. So that friction, right? Friction is drag, right? Like in physics and stuff like that. If you're dragging something, that is giving you a force that's going the opposite direction you want to go. So if you have your kickstand down or something like that, or your e-brake is on in your car, your parking brake, and you left that on, it's providing all this friction, and it's resisting your forward movement. It's trying to go back the other way. It's trying to stop you, basically. So there is resistance as well in these blood vessels. And so the more blood is in contact with the walls, and there's always going to be some, the more resistance there is. So as we get around this loop, there's been a long time of resistance dragging on this blood kind of reducing the pressure and things like that. So we'll see, that's one of the reasons that we see that big drop in blood pressure. Not only are we far away from the pump that's pushing it out, but it's been dragging the whole time and reducing that pressure. So by the time we're getting back to the heart itself, we want to make sure that we're making it as easy as possible to get it back up to the heart. So remember, our veins has valves in them. So if it ekes out a little bit, it's not going to scoot back, right? It's not going to lose that forward momentum. And they tend to have really thin walls and open lumens. Because again, the more open that channel is, the less blood is dragging along the walls, the more of it's shooting right through the center without that resistance or less resistance. So that helps to get it back as well. Okay? So we're going to be bringing that in today when we're talking about things that affect blood pressure and blood flow. So that's good. Other things. So remember, this week, if you haven't been doing it already, with our exam coming up, if you haven't been using those exam objectives and vocabulary lists already, this week you want to hit those hardcore, right? Because on our lecture exams, they're broken into multiple choice sections, vocabulary sections, and short answer sections. The vocabulary section is going to come from those vocabulary lists. So, I mean, you should know these terms anyway. You're going into healthcare, you got to know these specific terms. But that gives you the list. That your vocabulary terms will only come from that list that I've given you. So that's where you want to focus your efforts. And our exam objectives, particularly those in bold, if you're not doing them all, and that's fine, there's a lot, I know, but definitely spend some time with those in bold because those are your possible short answer questions. So you want to make sure you're practicing with those, writing them out, practicing and putting all your different answers together so you have a nice full answer for if you get that as a short answer question. The way that I have it set up in Respondus and in Canvas and stuff like that, it's randomized. There's big banks of questions of multiple choice and short answer and vocabulary, and then it just kind of grabs a bunch. So I think there's like probably, I'll have to take a look at it. If you remind me before Wednesday, I can take a look at it. But I think there's like 5 vocabulary questions or something like that, each worth 1 point. And it's going to select from that bank and then randomly give you different ones. Same with the multiple choice, same with the short answer. So there will be multiple short answer questions on there. Usually, off the top of my head, I think there's like 3 short answer questions. Each one's worth 5 points. Okay, so the bulk of the points come from the multiple choice questions. But you're talking about probably at least 2 or 3 of these short answer questions, each one 5 points, maybe something like that. So you're talking 10 to 15-ish points, 10 to 15%, if you want to think of it that way, of your exam, coming from those short answer questions. And you've got that clear guidance as to what possible short answer questions there may be. So that's why you really want to spend time with that, right? I think that overall, obviously it takes time. It takes time to study these things, to practice with them, just like learning to ride a bike. But overall, the vocabulary section and the short answer section, even though those seem at the onset like, oh, those are scary because it's just blank, there's nothing there, at least for the multiple choice I can pick it out, right? But for those 2 sections, you've got guidelines as to what's going to be on there. So really, those should be the easiest sections because you know what possible things you could see there and you can practice well ahead of time. So we definitely want you to do well on all the sections, but those ones should be easier as long as you're putting the time in, practicing those bold exam objectives, etc. Okay? Okay. So let's get this up and running. So we can talk about things like, we said, like hemodynamics and blood pressure and things like that. So that just shows us some of our comparisons between our arteries and veins. One of your possible short answer questions is asking you to compare, for instance, 5 different blood vessels in terms of their structure and their function, right? So we have our 5 basic types: arteries, arterioles, capillaries, venules, and veins. But we also found that there were all these subtypes as well, right? So we have elastic arteries and muscular arteries. Then we have our arterioles. Then we had 3 types of capillaries. Then we had our venules. Then we had our veins. So you have a lot of different options to choose from if you get that question asking you to compare 5 different types of blood vessels. Each one's a little bit different in terms of their structure and their function. So make sure that you've got something to say. But notice, that's a good example as well. Even though I keep saying we'll talk more about the exam on Wednesday, I keep talking about it now. Because I figure you want to know anyway. But notice that a lot of times with those short answer questions, I try to give you the choices of what to tell me as well. So if we're saying that you've got to tell me 5 different blood vessels, and we're saying there's probably more like 9 different blood vessels, you have your choice, right? If you can't remember the 3 different types of capillaries, it's okay to just say capillary and then use your other 4 different blood vessel types or something like that. Okay? Okay. So make sure to review the structure and function of those different blood vessels that we've gone through already. This is a minor point. It's just something we didn't have a chance to finish last time, but the fact that these blood vessels will branch, right? We know that they branch because that's how we get the new names of blood vessels, but a lot of times they will branch extensively and get more of these collateral channels so that we can make sure if there's a specific area of the body that may get blocked by a thrombus, right, or an embolus or something like that, that section of the body is not going to necessarily die. We have other alternate pathways to get there as well, right? We have backups. So an anastomosis is going to be an alternate pathway that reaches the same area. And that's why sometimes, even for veins will do that a lot as well. Even for veins, if you have like a varicose vein, like we said, where the blood vessel valves are breaking down and so the blood is pooling in there and it gets all wiggly like that, even if they go in there and they decide to tie it off or cut it off or remove it or something like that, usually they don't have to do too much because there's so many other channels for the blood to get around that it can still drain blood from that area even though it's missing that one channel. Okay? Okay, so again, not really critical information, but it is important to know that the body is covered and it's covered well in terms of other pathways. Okay, so now we're getting into, like we mentioned, more of the physiology, more talking about hemodynamics, etc. So we're talking about blood pressure and blood flow. So in blood flow, this is going to be, that movement per unit time. So we're seeing a given volume, oftentimes in milliliters, and how much of that is going to be moving per unit time. So it's usually in milliliters per minute. And we talked about it here as well, right? So we said this is often about 70 milliliters on average. This heart rate is could be about 70 beats per minute or something like that. So we kind of scale up from there and find out this is about 5,000 milliliters, which is about 5 liters or so in a given minute. But this is also something that we look at in terms of not only cardiac output, but we look at it throughout our vascular system. So if we're talking about blood flow, we're looking at how much blood is moving per unit time. But there's also blood pressure. So this is the force back behind it. So the units are going to be different. This is in millimeters of mercury. So millimeters of mercury is a weird kind of antiquated thing. We don't use mercury a lot anymore because it's very, very toxic and a carcinogen, etc. But once upon a time, our blood pressure cuffs had this J-shaped tube in them, like this, and it was filled with that cool silvery substance that's called mercury, right? They used to put mercury in thermometers too, and then every once in a while I wanted to break, and kids are like, oh, this is cool, look at how it moves, and they're all playing with it and stuff like that. It's really bad. They don't do that anymore. So in any case, there was a J-shaped tube filled with mercury, and in a blood pressure cuff, which we will be using on Wednesday, as they put in more air into the cuff, and as your arteries were putting pressure on the tubes of the cuff, it would move this mercury out of the way. So the more pressure is pushed on this side, it would raise it up on that side. And so they can measure it in terms of blood pressure as to how high that mercury had moved in millimeters. So millimeters of mercury is your standard unit for pressure. Now we're doing it for blood pressure. When we get to respiratory system, we'll also use it for air pressure. So even when you're like measuring atmospheric pressure, so we have a lot of crazy weather that's happening these days. High pressure systems are usually when it's clearer. Low pressure systems, like one that's coming, our atmospheric river that's coming. Get your umbrellas. Next couple of days, it's supposed to rain actually. It's true. But low pressure, you'll see They'll measure it in millimeters of mercury as well, or atmospheres. There's a couple different ways. So anyways, this is the driving force that's pushing our blood around. Now we say that the blood pressure itself is going to be high, closer to the heart in those arteries, and then it's going to be lower further down the way, right? And so what we find is that while the heart is generating this pressure, there are various things that are detracting from it, that are kind of lowering it as well. And so a lot of those come from resistance, and we were talking a bit about that before. So resistance is something, if you're resistant to an idea, you're like, no, I don't want to do that, right? So resistance is opposite to flow, and there are three different main sources of resistance to blood flow and blood pressure. One is blood viscosity. So viscosity has to do with how thick a fluid is. So think about something that's high viscosity is going to be like oil or syrup or honey or something like that. You pour it and it moves very slowly. So you can imagine that with your blood, if it had a high viscosity, so for instance, if your hematocrit was off, like you had a low amount of fluid or something like that, and so proportionally now you have more of those blood cells that are being pushed around with a smaller amount of fluid, it makes it thicker. That's tougher on your heart, pushing it around. That's also tougher in terms of your blood vessels, right? So blood viscosity comes into play, to be sure. Now there are various ways that we try to maintain that, right? We have kidneys and things like that. We have hydration. We have fluid input, fluid output, where we try to maintain that homeostatically. But that's one thing that can happen. Blood vessel total length. Okay. So we had mentioned that dragging along the walls of the blood vessels is what gives us this resistance. This is what kind of, in essence, reduces that blood pressure. So imagine, like we said, if you had your brake on, or if you had your kickstand down or something like that, or even if you were walking the hallway out there and it's super crowded, right? You'd be like dodging people. You might have to be up against the wall. You're like, oh, excuse me, pardon me. And if you're doing that, it's going to slow you down, right? So if you have a narrow hallway with a lot of people going through it, then it's harder to move through. There's going to be a little bit of drag. It's going to have to be a little bit slower. Meanwhile, if you go through that same hallway and there's fewer people, or it's a bigger hallway, then you can shoot right through the center. Not a problem. You can move through it very easily with less drag, with less resistance. So it's the same thing in terms of blood vessels. So a smaller blood vessel, proportionally more of the blood is going to be in contact with the wall being dragged. Whereas in a big blood vessel or a big lumen of a blood vessel, a lot of it can shoot right through the center, and proportionally there's going to be more with less resistance shooting through as opposed to being in contact with the wall. Okay? So the longer the blood vessel, the more we're going to be dragging along that wall. Now, there's not much that we can do about blood vessel length. We can't, contract our arteries and veins and bring them up short because there's too much resistance. So that is a factor, but it's not something we can control. One of the main things that we control in terms of resistance is blood vessel diameter. We can and do actively change that because we have that smooth muscle in the tunica media. So all of our larger blood vessels that have that middle smooth muscle layer can change their diameter. And when they open up or dilate, that means less resistance. And when they constrict, then that means more resistance. So we can affect blood pressure and resistance. We can affect blood flow by changing the diameter of those blood vessels. Kind of like early on, we talked about vascular spasm, where we're trying to close the blood vessel because there's a broken blood vessel or something like that. This is on a smaller homeostatic scale where we're just trying to, again, maintain blood pressure and blood flow, route blood to certain areas, right? Flood the field and things like that. So using smooth muscle, we can control that blood vessel diameter. So that's really the most important of the three, and that's the one that we kind of are going to be controlling the most. So this just goes through those three factors as we talked about: viscosity, blood vessel length, and then finally resistance itself having to do with blood vessel diameter. In fact, changes in radius or diameter of a blood vessel is to the fourth power, right? So if you have x squared, it's like that. It's like x times x. This is x to the fourth, like that, right? So it's not 4x, not 4 times x, x times x times x. So any change that we make in the diameter affects resistance to the 4th power. So it scales it up really fast, or it reduces that resistance very fast as well. You don't need to know that in terms of a number, is it to the 4th power, is it the 3rd power, or whatever. But you do need to realize that even small changes in diameter, which we always are making, have big changes in terms of resistance and blood pressure and flow. Okay. So anything that we do that changes the diameter can have an effect in terms of blood pressure and flow. So for instance, remember our arterioles. The importance of our arterioles that we have, which are our small arteries, is that they have a relatively narrow diameter lumen to them because they are working to protect those capillaries downstream. And so they reduce the pressure by narrowing their diameter like that. And then other things that can affect our diameter or the pathway through for blood can also affect that blood flow, right? So if we have fatty plaques that are being layered in to a lumen and stuff like that, it's going to be hard for the blood to get past that. So that drives the pressure up. So imagine, right, if you're squeezing a hose or something like that, or you're kinking a hose, what's going to happen? That reduces the downstream flow and it jacks up the pressure because now that fluid can't get through very well. So any reduction or increase in our vessel diameter has big changes in terms of blood flow and blood pressure. So what we find is that the flow, right, flow in terms of the volume that we get moving per unit time, is going to be related certainly to pressure. The more pressure, the more push we have behind it, then the faster the flow, the more flow we're going to get, if you will. So if we have arteries that are close to the heart with high pressure and then further down, smaller arteries down the way, we're going to find that that difference in pressure from high to low is going to draw that blood downstream, if you will. So what we find with that pressure, especially in the arteries, is that, remember, it's not exactly even as well. It's not one pressure. We have this changing pressure because at a certain part of the cardiac cycle, the ventricles are contracting, right? Ventricular systole, and we have new blood, a big tidal wave of blood that's coming down the arteries. And then we have the alternate part of the cardiac cycle where the ventricles are relaxing and filling, and there's no new blood coming down those arteries. So what we have is a systemic pressure that we're monitoring, oftentimes in those arteries. And when we look at it in the arteries, so check out this graph here. Here we see the blood vessels, starting with our largest artery, the aorta, then continuing through other branching arteries like muscular ones and arterioles, capillaries, and then coming full circle through the veins, ultimately in the superior and the inferior vena cava. This is blood pressure in millimeters of mercury on the y-axis there. And what we can see is that throughout our arteries, we see the spiking high points and low points, right? So it goes up, comes down, goes up, comes down. Every time it goes up, that's when the ventricles are contracting. That's called systolic pressure. Systolic pressure is when the ventricles are in systole. Diastolic pressure is down here when the ventricles are in diastole, when they're relaxing and filling. So systolic pressure and diastolic pressure. Now, to be sure, you can get an average, right? An average or a mean. And usually if you have a high number and a low number, you just divide it by 2 and then you have your average or a mean. But if you look at it, there's this kind of lag in terms of it going down to diastolic pressure. So it goes up very quickly and then there's this lag coming down. So in fact, when we see it down here, the mean pressure is not exactly halfway there. But the point here, and we'll talk about that mean arterial pressure coming up. We'll actually calculate it in lab next time. The point here is that in our arteries, we have this varying blood pressure, back and forth like that. And so with our arteries, we have systemic then diastolic, or systolic then diastolic, back and forth. But look what happens when we get to our arterioles, right? When we get to our arterioles, what we find is that we vastly reduce that pulsing type of pressure. So we get rid of that pulsing type of pressure so that by the time we get to the capillaries, it's nice smooth flow instead, right? So the capillaries are protected. So not only do we see we get rid of that pulsing sensation, but we also see a big drop in blood pressure. So that the pressure where we started out like 90 or so in terms of mean arterial pressure. Now we're getting, as we're entering into the capillaries, we're down at like 20 millimeters of mercury instead. So we're kind of protecting those capillaries by reducing the diameter of those blood vessels getting down to them. And notice we have no more pulsing as well. And then in terms of blood pressure, it continues to drop because we're, again, more drag as we're going through these blood vessels. And as we get to those vena cavae, you can see it's almost zero, right? It's just barely got enough pressure to get it back to that right atrium. And now we're going to start generating it again. So it's like those like merry-go-rounds they used to have at like little kid parks and stuff like that, right? The kids would get on and you kind of push them around and stuff like that. Now it's too dangerous, like too many like YouTube videos of kids flying off and stuff, so they got rid of them. Too much liability. But in essence, right, if the kids were on there, you would have a parent or a sibling or something like that pushing it every once in a while. And that's how we would maintain the speed, right? It'd be like push and then we go around, and then push and then we go around. That's what the heart's doing, right? We get it around the loop, gets back to the heart, and then push it out again. And that's enough pressure to get it around the loop again. Then we push and it goes around again, right? So that's what we're seeing here. We have enough pressure to get it all the way around the loop. Pulsing pressure at the beginning, get rid of that pulse by the arterioles, and then we have nice smooth but continually dropping low blood pressure as we get through the venous side instead. So that's our key point right there, where the arterioles are doing their protective job for our capillaries, reducing the pressure and getting rid of that pulse. So we talked about systolic pressure, we talked about diastolic pressure. I think those are vocabulary terms. There's also pulse pressure. So when we're taking a pulse, and we'll talk about it a little bit in lecture coming up here, and do it in lab on Wednesday. When you're taking a pulse, what you're feeling is that difference between systolic pressure when they're expanding out because they have that big tidal wave of blood, and diastolic pressure when they're doing that elastic snapback again. Okay? So the difference between the high pressure and the low pressure point, if we just subtract them, then that's what you get for pulse pressure. So if you had 120 over 80, and remember this is millimeters of mercury, for a systolic and a diastolic, the pulse pressure would be subtracting diastolic from systolic, right? So it'd be 40. So that one's an easy one. It's just the force that causes that arterial wall to pulse out like that, right? So it's a difference between those two. Mean arterial pressure, as we were talking about, it's a little bit different. It's a little bit more complicated. You take your diastolic pressure, and then you add 1/3 of the pulse pressure, and you get your mean arterial pressure instead. I wish it was the case you could just divide between the two, systolic and diastolic, but you can't quite. They don't really do a lot. I mean, mean arterial pressure is like, okay, overall, what's the pressure behind the blood going through the arteries? But as you know, they regularly measure systolic and diastolic because they want to see, okay, how much force do we have coming out of the heart? What is that pressure on those arteries, right? Is it too high? Is it too low? And stuff like that. So they're looking for that, and it should be within a homeostatic range. We don't want it to be too high. That's going to be hypertension. We don't want it to be too low. It's going to be hypotension. It's got to have enough force to push it all the way around the loop. You saw it's barely getting back. We don't want it to be too high because too much pressure on those pipes, on those blood vessels, can cause them to blow out, right? You don't want an aneurysm or something like that. Okay, or a stroke. So, as we mentioned, when you're taking a pulse, what you're doing is you're feeling that difference on an artery. So you can only take a pulse on an artery. If you try to take it on a vein, then you're going to think that your patient is dead because veins don't pulse. We saw that on the graph there. So you should know various common places to be able to take pulses. Okay? Radial artery is a very easy one. That's the most common one that we'll be using on Wednesday. But there's also the carotid one, right? So if somebody has a very weakened heart for some reason, you may not feel, there may be a big reduction in pressure, you may not feel a good pulse out on the extremities because we're always having a lot of drag there. So you may want to get close as you can to the heart and go to our carotid artery instead. So those are some of the common ones, common carotid artery. There's a facial artery that routes across the jaw like that. There's one that is the temporal artery, brachial artery. That's the one that we're going to be using to do blood pressure coming up. We're going to put the blood pressure cuff over that. And then there's a few on the lower limb as well. So if you are all hooked up with IVs and things like that in the hospital, they may want to check your blood pressure at the periphery. So they may do that one at the ankle and the top of your foot, the dorsalis pedis instead. Make sure that there's good blood pressure and flow down there.
They check for diabetes a lot. They check for the feet, make sure that the feet are still getting blood flow. Like
Oh, yeah?
If you're there for a foot ulcer or something.
Yeah.
You want to make sure you're getting good blood flow.
Right, that makes sense, because those people do have, or there's a number of different symptoms for people like that that can affect blood pressure, blood flow, etc. Yeah. Okay. So we've been talking about things that affect blood pressure and blood flow. As you saw, it's hard, it can be hard for the blood to get back to the heart. So we have various ways of helping the blood get back. We talked about how there are valves within these blood vessels, within these veins, most notably, that help on the venous return. But there's also a few other things that can help it along the way as well. So there are quote-unquote pumps that will help to push it along the way. The heart's the main pump, but in fact, there is what's called the respiratory pump. So when the lungs are doing their job, they also operate via pressure. And in fact, when they're doing their job in terms of getting air to come into the lungs and go out of the lungs, which is called ventilation of the lungs, overall, that action creates a subtle negative pressure in the chest cavity overall. Because the heart is also in the chest cavity, it is able to use that a little bit, that negative pressure that's in here, to help draw that blood back. Now, that's not going to be a big pressure, but like if you're laying down or something like that and your blood pressure is low, that's going to help to draw the blood back towards the heart, that negative pressure that exists in that chest cavity. So that's called the respiratory pump. So that helps a little bit. Muscular pump is one, when you're active, that helps a lot, right? So when they tell you to, on long flights or something like that, to get up and walk around the cabin or do some leg exercises and stuff like that, they're telling you that because they want you to use the skeletal muscle pump. So the veins are found right next to our muscles and going through between our muscles and things like that. So when our muscles contract and they get fat like that, right, when they contract and shorten and they get fat, they squeeze the blood vessels next to them. So when they're squeezing the blood vessel next to it, it squeezes it like squeezing the toothpaste tube. And so you know that any place you squeeze in the toothpaste tube, the toothpaste is going to come out one end because it's closed on one end, it's open on the other end. So that's like the valves that we have in the veins. Anywhere that we squeeze along the vein, if we squeeze it, it's going to not be able to get through the valve, and it's going to encourage the flow back towards the heart. Now, in a toothpaste tube, you should really do it from the end, right? Don't be one of those people where you're just grabbing in the center all the time. Come on, nobody likes that. Just kidding. But it is effective, though, right? Because it's closed on one end, it's open on the other end. So that is called the muscular pump, the skeletal muscle pump. When you're moving these muscles, it's squeezing those veins, and it encourages more blood flow, okay? So it can keep you from generating a thrombus, right? Deep vein thrombosis that we were talking about before, etc. Okay, so what we're seeing is that there's a variety of things that can affect blood pressure, right? Things that are going on in the heart, which is what we started with. Now we're seeing things that are going on with the blood vessels, right? The length of the blood vessel as well as the diameter, that's a big one. And things that are going on with the blood itself. All of those can affect blood pressure and do affect blood pressure and blood flow. So overall blood pressure is going to be what's going on with the heart, cardiac output, and that peripheral resistance. So if we have a lot of our blood vessels constricted, that jacks up our blood pressure, right? So you think about, again, like an adrenaline rush or something like that, not only does it have a direct effect on the heart, it affects the heart rate and the stroke volume, but it causes our blood vessels to constrict. Most of our blood vessels are going to constrict in response to epinephrine. And when we constrict them, now it's going to be harder to get the blood through them because it's a narrower opening. So that increases blood pressure too. But we can do that. It's not like, well, in some cases, in an emergency, yep, we flood the system with epinephrine, and a lot of them are going to constrict. Usually, we're doing it very targeted, right? So, oh, okay, so my legs are working a lot, I'm walking around, oh, yep, I need more blood flow down there. So I'm actually maybe going to dilate those to make sure they're getting more blood. Meanwhile, I don't know, my back muscles aren't doing a whole lot, so maybe we can constrict those, right? So we can route the blood to the places that need it as well, changing blood flow and blood pressure. All right, so in terms of coordinating that homeostatically, how do we control this? How are we going to affect this to make sure that we're getting the blood pressure and blood flow that we need? So there's going to be both short-term controls and long-term controls. So what we're getting to here in terms of the topic is a little bit bigger picture. So now we're kind of come full circle a little bit, and we've looked at this system overall, right? We looked at the blood, we looked at the heart, we looked at the blood vessels, and then we started talking about blood pressure and blood flow and what their effects on blood pressure and blood flow are. Now it's like, okay, now bigger picture, how does this contribute to the body and how is it coordinated with the other systems? How is it that when my legs are active that we get more blood pressure and blood flow down there? How is that coordinated? So we know that there's two main systems of the body that are about managing other systems, right? Nervous system, endocrine system. Nervous system is the wired system with direct lines going everywhere, releasing neurotransmitters. Endocrine system is our wireless system, where we're throwing out hormones into the bloodstream, right? So it actually uses the cardiovascular system to affect the cardiovascular system. But it also is a control system. And then what we'll find out is technically the kidneys are involved here as well because they are the main organs that regulate our blood volume, right? So we've got short-term regulation in terms of our neural controls and our hormonal controls. And then we've got longer-term regulation or control coming from our kidneys. Remember, renal, like we saw renal artery and renal vein, means kidney. So these are the ways that we control and coordinate this system to make sure it works with the other systems and it maintains homeostasis overall. So each time we do these systems, because now we're getting to the end of cardiovascular system, but each time when we do these systems, after we understand the components of the system and how it works, we kind of get this bigger picture. We scale out and we look at the big picture in terms of how it's coordinated and controlled. So that's what we're doing here. But we'll do it with all the systems, okay? And to a certain extent, we're going to see the same answer. There's always going to be nervous system. Yep, it's a boss. Endocrine system. Yep, it's a boss. And then there'll be some sort of like little localized control and things like that as well. And we do have that here too. Okay, so what are we saying here? Nervous system. What areas of the brain then? It's not the whole brain. What areas of the brain have a direct effect on our cardiovascular system? Well, at the end of 201, which you're like, don't talk to me about that. I've purged all of that. I don't have to know that anymore. You do. It comes back around, right? When you have patients, they're still going to have nervous systems and skeletal systems and muscular systems, stuff like that, right? So for my sake, as a future patient, potentially, please don't forget that stuff, okay? Or this stuff. I can tell you in my direct experience, because I am getting older, you're like, nope, you're old. You've achieved it. Good job. I have had former students as medical professionals for me in a hospital or whatever. Yeah. So not only do I care about you as students and your success and your pathway and stuff like that, but I have a personal vested interest in it. Because I don't want a former student of mine coming in. I'm like, oh, no, I remember this person. Get me somebody else. Right? So I can happily say that every time I've seen one of my former students, it's actually reduced my heart rate and my blood pressure and things like that because I know they know their stuff. All right, so hearkening back to the nervous system, when we're talking about brain, it's not all parts of the brain that are necessarily in direct control of our cardiovascular system. We have a cardiovascular control center down in the brainstem. Overall, if you remember, as we worked our way down in the brainstem, you got down to more and more just basic life-sustaining functions, right? Up here, it's about dreaming and personality and things like that. But as you get down towards the lower areas of the brain, right? So the midbrain and the pons and the medulla oblongata. And then it's just about those basic life functions. Like we said, cardiovascular system, respiratory, throwing up, all these various things, right? So they're in the medulla oblongata. That's your main area where we have our cardiovascular control center. So that's where we have neurons that are coming from there that are routing out to the heart, routing out to our different blood vessels as well. So we need to remember that the medulla oblongata is the main area of the brain that's in control there. The autonomic nervous system, remember we had kind of these two branches of the motor output. We had somatic, which is voluntary, going to skeletal muscles, and then we have autonomic, which is like the automatic functions, where it's like, I don't have to think about it, it's handling it, it's controlling it. So this is mainly going to be autonomic, right? So for autonomic, we had sympathetic. What's the phrase that goes with sympathetic? Fight or flight, right? So sympathetic and then parasympathetic is going to be the opposite. It's rest and digest instead, right? Now for cardiovascular system, it's going to be kind of what you think of. Sympathetic is going to tend to increase heart rate, increase blood pressure, constrict blood vessels and things like that, right? And parasympathetic is going to be the opposite. It's going to slow down the heart rate. It's going to decrease our stroke volume, etc. It's going to calm things down. Now, that's not always going to be the case. When we get the digestive system, it's actually the opposite. Parasympathetic is more stimulatory instead. But what we find is with these homeostatic feedback loops, like usual, we think, okay, well, we've got where it should be. That's going to be controlled in now our medulla oblongata. I should point down there instead. But we've got to have our receptors that are telling it what's going on now. We've got the set point as to where it should be. And then we've got some sort of motor output, as we were just talking about autonomic, that can make adjustments as necessary. So these are some of the different types of receptors that we have that monitor this situation. We have baroreceptors, pressure receptors, that are found in various areas that tell us what the blood pressure is right now. Is it too high? Is it too low? Do we need to make adjustments, right? And we have some in some key areas that we'll see. So we have baroreceptors, we have chemoreceptors. So we said that the blood itself is about delivery, for sure. And we've got to deliver these things like respiratory gases and fluids and nutrients and things like that. So we're monitoring those chemoreceptors. And not only do we have those receptors that are telling us what's going on out in the body, but we also have the influence of higher brain centers as well. So even though it's the medulla oblongata that has direct control over our blood vessels, obviously there are aspects of the cerebrum and stuff like that that will trickle down and influence it. So the limbic system, etc., the emotional brain, definitely can have an effect on blood pressure and blood flow, right? If we really start thinking about the fact that we have a lecture exam coming up and a lab practical coming up and stuff like that, just thinking about that can increase our blood pressure right now, right? So higher brain centers can have effect on it as well. And then different types of blood-borne chemicals, like we said, hormones as well as other types of chemicals can affect what's called vasomotor activity, these blood vessels and how they're responding. So this is our typical feedback loop. You don't have to kind of go through all the components and be able to list them or anything like that, but these are some examples of, again, baroreceptors. We have baroreceptors in the carotid arteries. So we see the carotid arteries are going up to the head and they're going up to the brain. So that's a good place to monitor blood pressure. We want to make sure that the brain is getting enough blood pressure and blood flow, right, and not too much. There's also some in the aortic arch as well. So they tell us what's going on. If we need to adjust it, that's going to be coming out of our cardiovascular center in the brainstem. And then we can make changes to the heart. We can make changes to the blood vessels if we need to. If the blood pressure was too high, that's going to be picked up by these baroreceptors, and we can decrease heart rate. We can decrease our contractions. We can dilate those blood vessels. And that's going to bring everything back down again, right? So we can do that either way. If it gets too low, we can do it the other way. Increase heart rate, increase cardiac output, constrict blood vessels, and that's going to bring blood pressure up. So we're always monitoring this situation, right? So we have nervous controls, like we said, that are going to be monitoring things like different types of chemicals. Oxygen levels, carbon dioxide are some of the key ones where we are measuring those. And those chemoreceptors are found in those other key places like the carotid arteries, because we want to make sure the brain doesn't go down because it's handling everything, and even the aorta, because the aorta is where it's going out to the body. So we should make sure that there's enough blood pressure there and oxygen levels, etc. So we have these different types of checkpoints. These are other chemicals that can affect blood pressure and in fact increase blood pressure. So norepinephrine and epinephrine, right? That's your adrenaline. That can affect blood pressure. So that can cause blood vessels to constrict and heart rate to go up. Antidiuretic hormone. We'll talk about this one when we get to the urinary system. But what's a diuretic do? Diuretic makes you pee, right? Makes you pee more than what your fluid intake is. But this means no pee hormone, right? Anti-pee hormone. So this makes you pee less. What that's doing is it's helping to control blood volume, because changes in blood volume also affect blood pressure. So if we can hold on to fluid, that's going to maintain blood pressure. So if you're dehydrated or something like that, we're going to release this hormone so you reduce the amount of urine that you're losing, and we're retaining fluids instead to keep that blood pressure up. Angiotensin II is part of a mechanism. Renin starts that off as part of a mechanism called the RAS mechanism, which can affect vasoconstriction, so that can increase blood pressure. And then there's a variety of different factors that come from like blood vessels that are broken or tissues that are affected in certain areas that can also affect localized blood vessel constriction or dilation. So for instance, right, if I have a cut or a bee sting on this hand, I need more blood flow to that area on that hand. Just that area, not this area, this area. I need it on that hand, not this hand. So I can get redness and swelling. I can get increased blood vessel diameter and blood flow here because of some of those local factors, local chemicals that are released that are part of the inflammatory response, right? So there are local chemicals that can certainly affect blood pressure as well. These are various examples that decrease blood pressure that can have the opposite effect. So nitric oxide is a good vasodilator. This one we'll talk about as well. I like this one because it's pretty cool. It's called atrial natriuretic peptide. This actually comes from, look at that term, the atria. So if the blood pressure is too high, the atria are going to get stretched because they're receiving all this blood back and it's too much. So they can release a hormone that then goes down to the kidneys and says, oh, you know what? Do me a favor, get rid of some sodium. Sodium creates an osmotic drag and drags the water with it. So as the kidneys are secreting sodium, they're also getting rid of water, reduces blood volume, reduces blood pressure. Atria go, that's better. So various ways that we can adjust blood pressure, either by tweaking the blood or the blood vessels or the heart itself. Alcohol, oh, that's a diuretic, right? Because it inhibits antidiuretic hormone. So that's why when you're drinking alcohol, you become dehydrated. You're like, what's the problem? I was drinking all night. I should be well hydrated. The problem is that the alcohol in there, and if you had any caffeine in it, some sort of vodka Red Bull thing, that's a double whammy on the kidneys. Both of those are diuretics. So you're going to be losing more volume than you're getting. So every time you take a drink, you're becoming more and more dehydrated. Yeah? Okay. So like we said, chemicals, the brain for short term and local, and then renal regulation. This is by monitoring and changing the blood volume, how it can affect blood pressure. But it takes a bit longer, right? If we do vasoconstriction or we release adrenaline onto the heart, immediately almost it goes boom, 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 boom. Or the blood vessels constrict. It's like, oh, I feel that rush coming on. But blood volume, it takes a while to filter to pee and stuff like that. So this is certainly a mechanism that can affect blood pressure, but it takes longer to do it. But it is something that the body uses in terms of the kidneys reducing or increasing blood volume, which affects blood pressure. Okay. So, like we said, that renal regulation has to do with blood volume as well. It is the kidneys are involved also in terms of that, what's called the RAS mechanism, where it actually works as part of a vasoconstrictor type of thing, and it affects sodium levels in the body. But like we mentioned, in terms of the renal, this is kind of like our third level of control. Okay. So this section has to do with blood pressure as well. It's talking about measuring blood pressure. It's using a tool called a sphygmomanometer. Sphygmomanometer, a big fancy term for blood pressure cuff. So we'll use that in lab, and we'll talk about that a bit more in lab. Okay. So what I'm going to do is I'm going to bump over this here in lecture, because what we need to do is we need to get to talking a little bit more about the distribution of blood and distribution of substances to our different tissues. Okay, so there's a topic I want to get to today for sure. So we'll talk more about measuring blood pressure in lab. We'll talk about the importance of maintaining blood pressure homeostatically so it's in the right range. We don't want it to be too low or too high. Too low is called hypotension, right? Hypo means low. Hypertension, like chronic hypertension, is going to be where it's too high. So here's our systemic and our systolic and diastolic, or 140/90-ish. Those are kind of moving targets over the years, but that would be considered hypertension. And there's like borderline, etc. But we don't want it to be too high or too low. There are different types of hypo and hypertension. This one is one that probably everybody has experienced one time or another. Orthostatic. So orthostatic is when you change body position, right? If you're laying down and all of a sudden you stand up, a lot of that fluid shunts via gravity down towards your feet, away from your head. And so what your blood vessels do is they constrict very rapidly down there to make sure it goes through and comes back up towards your head and doesn't pool down there too much. But sometimes that can be a little slow in terms of the response, and so you feel a little lightheaded and you have to sit down, right? Or you have to put your head between your legs if it gets really bad, because now you're helping that blood to get towards your head using gravity that way. Or one of the best ways to increase blood pressure to your head is actually to cough as well. So by coughing, when you cough, you are again changing some of the blood pressure in near the head and near the chest. And so when you cough, that increases your blood pressure temporarily. It's a good way to kind of get that blood flow going back up to your head as well. But orthostatic due to position, chronic is where for whatever reason it's low. And then acute is where there's like circulatory shock. So shock itself, while you hear commonly it's like an emotional thing, you're like, oh, I was shocked to hear that. Circulatory shock is different, right? Chronic low blood pressure, where it's lower than it should be, that's hypotension, where it's like, oh, maybe I feel a little woozy every once in a while, or I just don't feel myself or whatever. But circulatory shock or acute hypotension is where there is a precipitous, a very fast and very low amount of blood pressure all of a sudden, to where, like we said, you'll pass out, or your blood is not getting to the various organs as it should. Okay? So circulatory shock can come around for a variety of reasons, but that is a key and critical type of change in homeostasis, as opposed to just hypotension, where it's like, oh, okay, hold on for a second, I'm going to have to address that. There's a hypertension. We won't talk a bunch about that. There are a couple different types. They have a hard time figuring out why hypertension occurs regularly. So there's a lot of factors that are involved, like you see listed there. But they often have a hard time figuring out why somebody has hypertension. So usually what they do is they treat the symptoms rather than the source. Because if they can't find the source, then what are we going to do? How about a diuretic? If we give you a diuretic, you're peeing more, your blood volume goes down, necessarily your blood pressure goes down. Problem solved. Doesn't really solve the problem, but it treats the symptoms, and that's kind of one of the easiest things. So primary is where they can't find the source of it per se. Secondary is where they can identify it, right? So if there's an issue in terms of blood vessels or some of our control mechanisms, etc. All right. This is the section that I wanted to get to. talking about the blood flow through the tissues, because when we're looking at those blood vessels, what we were talking about is making sure that we get blood to all the different organs, to the cells that make them up. All of these living cells that need oxygen, that need fluid, that need nutrients in order to survive and perform their duties. We got to make sure we have enough blood pressure and blood flow to get things out to them. So we want to make sure that we have adequate what's called perfusion, that it goes through that tissue and is delivered like that. And you can see a bunch of different examples as to why we would need to make sure that we have adequate blood flow to different organs and different tissues around the body. Now, in some cases, with our larger blood vessels, all we're talking about is getting it from one place to another, right? So for our thick-walled arteries and big veins and stuff like that, nothing's getting across the wall. It's all about just routing it as quickly as we can to or from a particular area. So it's kind of like the freeways that we have out here, like the 202, right? You're trying to get somewhere fast, you just get in line and you go, right? Everybody's going the same direction. But what we'll find is once we get to the capillaries, we said the capillaries are a different situation, right? The capillaries are the exchange vessels. This is where we do want it to be nice and slow, low pressure, etc., so that we have time to exchange things across the walls of these very thin blood vessels. So that's where we can actually make deliveries to the tissues and get things back from them, right? So if you had, like we mentioned, if we have the Amazon driver zooming through your neighborhood at 60 miles an hour, not going to be able to do exchange, right? Just whoomp, gone. Made it through the area, but didn't do exchange. It's very important to do exchange. So the capillaries are all about exchange in that way. And so if we look at the velocity of the blood, you can see how the velocity drops, right? It starts out, this isn't pressure, right? This is centimeters per second. This is like miles per hour. This is how fast, boom, boom, we're going through. Notice it drops, right? As we get that resistance going, smaller and smaller vessels, it drops. But that's okay, because at the capillaries, we can see it's like, 5 centimeters per second or something like that. It's very slow, so that, again, we have time to do the exchange before we go whipping out of the neighborhood again and start speeding up as we get to those larger venules and veins and on our way back, okay? So we want to make sure that we can get adequate flow to these different areas. And in fact, the blood vessels, because of local conditions, can do that as well. They have their own little control called autoregulation as well. Remember how I was talking about if you have a bee sting over here, we want flow over there, and we don't want it necessarily on the other hand where there isn't that. So there's a lot of different chemicals in the local environment that can affect blood vessel diameter in, for instance, arterial and stuff like that, so that we can deliver more flood to it, or flood the field to an area that is affected, etc. So what you're seeing is, for instance, different types of chemicals that can affect it. So for instance, if we have a drop in oxygen in the surrounding tissue, we better dilate that blood vessel. You need some more blood flow because you're kind of starving for oxygen. If there's a lot of carbon dioxide, you're accumulating some of those waste products. Let's get you some more blood flow as well. That's going to cause our blood vessels to dilate. So there are certain things that will dilate blood vessels, certain things that will constrict blood vessels as well. So antidiuretic hormone, not only is it no pee hormone, but it works as a vasoconstrictor, which helps to increase blood pressure again, right? So epinephrine, norepinephrine, for the most part in blood vessels, epinephrine is going to cause vasoconstriction. Again, it's going to jack up blood pressure, etc. So there's a variety of things that can affect the diameter of those vessels, like arteries and veins, that can then control blood pressure and blood flow in local areas. So these are what are called intrinsic controls, little local controls, and then some of the things that we were talking about before are called extrinsic controls, coming from the brain, coming from the endocrine glands, and things like that. Okay? So all of these things will affect what's going on at the blood vessels and their delivery of blood down to our tissues. But this is where we start talking about our capillaries, because our capillaries is where finally we get the blood to the tissues. Now we've got to be able to do that exchange. So we need to understand how we get these things to exit and go through the wall of the capillary, and how we get certain things to come back, right? Nutrients, waste products, fluids, things like that, respiratory gases. How do they know to go and dip into the tissues at the tissue levels and then come back again, right? How do we know oxygen is going to go that way and carbon dioxide is going to come in? Well, for many of these things, like oxygen, like carbon dioxide, like nutrients, stuff like that, it's all about gradients. It's all about where is it high and where is it low, and it's going to diffuse from wherever it's high and wherever it's low. So think about it, right? Arteries to arterioles, do they have, arteries and arterioles have high oxygen or low oxygen? High in the systemic circuit, that's why it's red, right? So in the blood arriving to the capillaries, it has a relatively high oxygen content compared to the tissues where we're using up that oxygen to make ATP aerobically. So oxygen diffuses from the capillary into the tissues just according to its gradient. Meanwhile, when those tissues are really active, they're pumping out carbon dioxide as a byproduct of that aerobic respiration. So it has a relatively high concentration of carbon dioxide in the tissues compared to that fresh blood that's arriving there. So carbon dioxide diffuses from the tissues into the blood instead, right? Same thing for nutrients. A lot of nutrients, fresh nutrients from the intestine, high concentration in the blood, low concentration in the tissues, diffuses out. Waste products kind of go the opposite way. So for those things, for lots of those things, it's all about diffusion. Where is it high and where is it low? It's going to diffuse and go from high to low to reach equilibrium. Okay? The thing that's different about that is fluid flow. So in terms of water, we have to make sure that water gets into the tissues, but it doesn't just stay there. We can't load up the tissues and cause them to swell up. That's called edema. We don't want that. Okay? We want nice fluid flow in, but we've got to collect it back again as well. So how do we get water to go out and get water to come back in? Everything else, it just goes one way. Oxygen goes out. Carbon dioxide goes this way, right? But water, we need to go both ways. So how do we get it to do that? So here's the deal with our fluid flow. So this is the wall of the capillary that we're trying to get through. We're either going to be zipping in between those epithelial cells or going through them, right? So there are various ways that we can kind of transit that very thin wall of the capillaries. But when we're talking about that fluid flow, let me get to the diagram here because it's going to be better than looking at all those little acronyms. When we talk about fluid flow in the capillaries, this is what we're seeing. So on the left side of this diagram, we see the arterial end. This is where the blood's arriving on the left side there, okay? On the right side then is where it's going to dump into a venule. So what we're seeing there as we go along is we're seeing some differences in hydrostatic pressure. So hydrostatic pressure is basically blood pressure, right? It's fluid pressure. Whoop, blood pressure. And we know that as we go through blood vessels, there's that drag on the blood that drops our blood pressure, right? It's highest near the heart, and then it's constantly dropping and dropping and dropping as we get down here, right? So even along a capillary, at the beginning of the capillary, the blood pressure and hydrostatic pressure is a little bit higher compared to the end of the capillary, just because of drag. These are the smallest blood vessels, so there's a lot of drag on that blood, okay? So take a look. At the beginning of the capillary, it's about 35 millimeters of mercury. By the end of the capillary, it's dropped down to about 17 millimeters of mercury. It's about half the blood pressure even along the length of that capillary, okay? So what we see is that there's a little bit of half of the blood pressure is kind of dropped away as we go through the capillary. But at the beginning, we have a fairly high blood pressure at 35 millimeters of mercury. Now there is one other larger pressure that's working against it. That OP that we see right there is osmotic pressure. So OP is osmotic pressure. And osmotic pressure again has to do with how much water there is and how many solutes there are in a particular solution. And so osmotic pressure, remember, like we have albumin. Albumin is in the blood and it helps to draw the water back in. Now that osmotic pressure, take a look at it. The osmotic pressure that's trying to come back in is about 25 at the beginning, it's about 25 at the end. So we have these opposing forces, okay? osmotic pressure is constantly trying to suck water back in. But at the beginning of the capillary, there's enough blood pressure, hydrostatic pressure pushing out, that when those opposing forces go up against each other, we have 35 pushing out, and we have only 25 trying to come back in. So when we add those together, or subtract them, really, we have this net 10 plus 10 pressure, net filtration pressure, pushing fluid out at the beginning. So between those two opposing forces, at the beginning of the capillary, the blood pressure, the hydrostatic pressure, is winning, and we're pushing the water out, which is exactly what we want. By the end of the capillary, now the blood pressure, the hydrostatic pressure is weakened, but the osmotic pressure is still the same at 25. So now by the end of the capillary, that dynamic is switched, right? Now the osmotic is winning because we have a plus 25 that's trying to draw it out of the tissues and back into the blood, and we have this weaker 17 trying to go the other way. So net filtration pressure has switched. Now we're drawing it back into the capillary by the end. Okay? So what this explains is that this explains how fluid moves back and forth through the capillary wall. And this is also referred to as bulk flow, where we're moving fluid as well as some solutes according to their kind of pressures that we see here. And we see two main pressures that are involved. This is blood hydrostatic pressure. And this is, in essence, our blood, and sometimes they call it colloid osmotic pressure. Okay? So those are the two pressures that cause this fluid to move. And at the beginning of the capillary, the blood hydrostatic pressure is higher, so we get a net movement out, which is exactly what we want. By the end of the capillary, now the blood hydrostatic pressure is weaker. Now the osmotic pressure is winning, and we're drawing that fluid back in. Okay? So I wanted to make sure, I know we ran right to the end there, we're like 2 minutes over, but I want to make sure we at least hit this topic. We're going to review this topic again next time when we get into our finishing this up and reviewing. But this bulk flow and fluid exchange is a kind of bigger topic that takes a little bit more time to understand. And it's also a possible short answer question. So we got to make sure that we understand it pretty well. Okay? All right, so we'll hit this again when we get together next time. Morning lab people, you are free to go. And late lab people, we'll see you in just a minute.